Hi, everybody. It's good to see you after last night's wonderful opening. How about a round of applause for our 5 award winners? They are amazing. They were amazing. I know that everybody can't make it to opening night, but I want to encourage you for the conferences in the years to come. You got to come to opening night. It's really special, and it's special because we honor special people who have led the way. And there's an authenticity and a kindness and a camaraderie that represent what Jay was just talking about, that we are a community, and a community is stronger together than it is of its individual parts separately. So it was really special, and it's an honor every year to be able to give those awards. Jerry Crossan is my current board chair. Board chairs serve 2 years after serving considerable years on the executive committee. They do a lot of work. It's not an honorary position. I lean on them heavily, and each year I get to work with a new board chair who is a seasoned leader in our field, who brings wisdom and support to me and to our staff. And it's really a wonderful thing. Last night I gave a shout out to Bobby Ferguson as past chair for his efforts, and they were considerable. And I also talked about how instrumental he was in our ethics launch, which really helped us rebrand. You know, look, you guys know the story. About 8 or 9 years ago, we brought on a new team, and we regrouped, and we built an ethics code, and we enforced it, and we did not let everybody in, and we got sued. We got sued hard. I got served actually at the Washington conference, and that resulted in a lengthy 2-year battle of fighting one particular lawsuit. And the reason I mention it is twofold. One, because we held our ground, and it's key to what we are, right? And we didn't do it because it was going to improve the association, but it did. People saw it and came. We did it because of the right thing. And Jay Crossan was instrumental in that process. There was any of you who know anything about civil litigation for millions of dollars know that it's brutal, and extensive day-long depositions were taken. Jay had never had his deposition taken for 2 days before. I'm a trial lawyer, so I was thinking, I thought it was kind of fun, but for a normal person, it's torture. And Jay was such a ray of light and strength during all of that. So Jay, I don't think I've thanked you enough for that, and you really held us up. Our keynote speaker is coming soon, but this is a few minutes when I get to talk about what our association is all about. I did that a little bit last night, but I want to talk about it more this morning in the context of what's going on in our world and what's going on in our profession, because we have to get right-sized about our environment in order to do the right work, right? There's some badness out there. We have some battles to fight as it concerns the current environment, not the least of which is a historic addiction epidemic that has gotten worse. So we have to take a look at that in order to understand how we come out of it. So we're going to talk about that, but what I want to talk about it in the context of is the role of leadership in that process. NAATP was built on and continues to be a leadership organization. Leadership comes from the top. And so we're about building good leaders and guiding the profession forward through that. And so that requires innovation, right? Leadership organizations that don't innovate fail. But there's another piece of that, and that's what I'm talking about when I say holding our center. We need to innovate. We're going to talk about all those innovations. We can't be afraid of that innovation, but we also have to hold our center. In other words, we have to hold on to that core, which has built us to the point that gives us our opportunities today. And at times of crisis, and this is an addiction crisis. It's a crisis. That's not an overblown word. 800 people dying every day. 800 people dying every day from this disease is a crisis, and it's not being adequately addressed. And so we have to talk about it that way. And in order to do that, we have to have a real clear look at what it is we have done right and where it is that we need to go. So I'm going to start with Elmo. And I mean this as a bit of lightheartedness, but I also mean it very seriously. And some of you may recall this, but in January of this year, Elmo checked in on us. Do you guys remember this? Do people remember this? Yes, not as much as I do apparently, but some people are nodding their heads. So the lovable, adorable Sesame Street character Muppet wrote a post that said, "How is everybody doing?" And it went viral, and it touched a nerve that has rarely been seen in our country. It received 200 million views within a couple of days, and the New York Times covered it in a very meaningful way. There's also an article by Dr. Everly that's attached here that says, "What happened when Elmo asked, 'How is everybody doing?' A question asked by a Muppet yielded an unsettling answer, but you can help." The New York Times wrote, so these reports started coming in. Something happened when Elmo asked our country how it's doing. People said, "Somebody asked me how I'm doing, and I'm going to tell them." Elmo asked a question that shone a light into the darkness of psychological distress gripping our country. It opened a yawning chasm of despair. It exhibited a national trauma dump. I was touched by it when I saw there's something happening here because of what's going on in our country that is very much related to the addiction crisis, that touched people to the point where one individual wrote, "Somehow this actually legit helps me feel better. Thank you, Elmo." So if this character caught our national attention in the way that it did, it says something about what's going on in the world. And so as we move to the substance of this conference, let's take a look at what you can think of as an environmental scan. Addiction treatment, as we have known it, is in the balance as we move forward. We have an addiction crisis. 48 million people in this country have a substance use disorder. 48 million people meet the criteria for a substance use disorder. That has increased dramatically since COVID. It hasn't technically doubled, but it's pretty close to having doubled. And it hadn't moved in many, many years. It was in the mid 25 millions for a very long time. So something got broken during COVID, and it turned people to drugs and alcohol. We know that the lethality of opioids is a historic add-on to what was already an addiction crisis. We forget sometimes that alcohol remains the biggest killer. Alcohol remains the biggest killer by far, not even a close call. And there was a 23% increase in alcohol deaths from 18 to 21. So we're looking now at 300 deaths annually, if you put all the substances together. 300,000 deaths annually with all the substances. That's, as I said, 800 a day die from, I struck out overdose. It's poisoning. Overdose is this term that suggests, again, some sort of immoral choice. What happens when people die from these substances is that they have been poisoned to death. So this is the addiction environment. This is the market that we serve. And we do it at a time of a society that is very much unwell. We are divided and increasingly spiritually unwell. I don't think it's even debatable. There continues to be a tremendous equity imbalance. Where you sit socially in this country determines when you will die. Where you sit socially in this country is the determinant that dictates what health care you will receive and how well you will be. And all of that is indicated by the Elmo Wellness Check. So now let's take that environment and look what's happening in our field. In many ways, our field is at its height because we have more tools than we've ever had, tons of opportunities, great research is being done. We're saving people's lives left and right, absolutely. And we're doing better at it, I think, than we ever have before. But things are changing, and we have to be very nimble as we look at these changes. So let's think about it in three areas. The first is we have a very rapid pace of move of our clinical model from a social to a medical model. That's been going on from the beginning. If you look at the entire timeline of our work, it begins as a social movement with Alcoholics Anonymous in the 1930s and 40s. It's not medical care. It's not clinical care. It's not professional care. It's a social movement, and a wonderful one it is. And it has saved so many of our lives as a component of other things. But this has been a steady progress of moving from a social model to an institutionalized social model, essentially, to now what we talk about as a medical model, although it will be difficult for us to describe exactly what that medical model looks like. But it's healthcare, right? We must be healthcare. If we do not continue to assume our rightful place in the broader healthcare universe, we will not be successful. We cannot exist successfully as a side part of this country's healthcare system. People talk about now having moved from program care to individualized care, or somewhere in the process of moving from program care to individualized care. In other words, it's not a treatment model for everybody. It is an assessment of an individual's condition on a continuum of substance use disorder and figuring out what that person needs based on that. It might be residential. It might not be. That makes sense. And we also talk about moving from simply substance use disorder or alcohol use disorder only to something that we now call integrated care. We used to think of it just in terms of dual diagnosis, right? Do you do dual diagnosis? The DDCAT, the Dual Diagnosis Assessment Tool, which is a very good tool, by the way, to measure one's co-occurring capacity. But now we're talking about, from two perspectives, what integrating behavioral health and substance use disorder look like. I'm not making a pitch that it be integrated or not integrated. That's not it. But their integration is happening at different levels. It's happening from the larger behavioral health care side, saying we need to learn how to do substance use disorder care. So there's this piece of behavioral health care that's just trying to subsume substance use disorder care, and then we too are trying to be very aware of how we treat the whole person. Put the head back on the body, as one of our presenters is going to talk about this afternoon. And all of that makes sense, but is integrated care good care? Absolutely. All medical research, all social science, mental health research indicates that integrated care is good care, but that doesn't suddenly make it happen. And it certainly doesn't so we're going to, treat more behavioral health than we have before, but there's no system to pay for it. And how do we build those systems? But that's what we have to do. So this is happening in our marketplace at the same time that our marketplace is becoming more competitive than it ever has been, and is consolidating into larger programs. Whereas once this association was a whole bunch of small programs, 60 bed, 50 bed, 20 bed Minnesota model programs. Many of us got well at those kinds of programs. They still exist, and I hope they never stop existing. We support them tremendously, but it's hard for those organizations to stay in business right now because the big guys are taking them over. And I'm not mad at the big guys. This is the market system. This is how this works. But our field is consolidating into fewer entities who hold more treatment facilities. I'll show you the bubble chart that you've all seen before in a minute to sort of talk about that. But we have to figure out how we exist in that competitive market. And let's not mince words about a flawed third-party reimbursement system. It doesn't work. Parity has been a law in this federal law in this country for over a decade. It's not implemented and it's not enforced, and Congress hasn't done its part. We've tried, but getting financial penalties approved by the current Congress when insurers violate parity has been an impossibility. And I look forward to the day when it's not an impossibility. There was, in a pending piece of legislation a year ago, a provision that would have given the Department of Labor authority to levy significant fines on parity violations, but it got bumped out of the final version of the bill. And so, we continue to fight that fight, and that's why we do policy work. But it's simply, we operate under a very difficult to manage third-party payer system. It's managed care, right? Once upon a time, managed care, some of the folks who were up here last night remember treatment before managed care. It was better. So managed care changed our field dramatically. Managed care means the doctor doesn't decide what you need. So the guy who pays the bills decides what you need. That's what managed care is. It was created under the Nixon administration to combat Ted Kennedy's attempt to put national health care in place. That's where it came from. And it was a cost savings. It was a cost savings. It's the market in which we live, but it doesn't work well for us. So with that in mind, we're going to move forward. And so I want to talk about this holding the center business again a little bit. I think it's very important to think about where we are historically. About 1920, the renowned poet William Butler Yeats wrote a poem called Slouching Toward Bethlehem, and in it he described a disastrous situation where our society falls apart. Think about what was happening in 1920. 1 million people had just died from a pandemic, Spanish flu. This isn't the first time we've been through this, folks. 1 million people had just died from the Spanish flu. It was horrible. More than died in World War I, which had just ended and was a colossal destruction in so many ways in our entire world. And it was a time of the haves and the have-nots in a very significant way. And things did not look good. And so William Butler Yeats talked about a great beast slouching toward Bethlehem. And he said, if the great beast reaches Bethlehem, the center will not hold. Something fundamental that is our core that holds us together will break. Now it's the 1960s, and Joan Didion, great feminist and cultural anthropologist, studied the 60s from within and without. And toward the end of the 60s, she saw the promise of the 60s failing. She saw a movement coming that did not look healthy or well. And she saw what had been an experiment in free use of drugs and alcohol turn very, very dark and lead to much of the addiction crisis that we have today. And in her White Album, she quoted Slouching Toward Bethlehem and said that she, at this point in time in 1968, I don't think that the center will hold. So what I want to say about that is that this is not, despite the way that I may sound this morning, gloom and doom. This is opportunity. And it's opportunity when we know what the history is, and it's opportunity when we know what we face in all of these areas. So what I believe, and I believe this association is all about, is that our center will hold when our leadership has the unified wisdom and commitment to hold it. And if we don't, we'll come apart. We come together, folks, to do this work, or we risk coming apart. I believe that, and I believe that is why NAACP and NAATP is here. Okay, we're going to move into our sessions, and we're going to talk about 15 items that I believe are the core pieces that will cause us to move together, hold our center, and innovate at the same time. We're going to talk about the medical model of care and how 12-step facilitation fits into that. We're going to talk about the very complex pharmacology that is both a tool and a problem if we don't understand it in the big picture. We'll look at medication-assisted treatment, harm reduction, and how those things relate to the concept of recovery. We'll talk about the unique role of residential care in the continuum. Residential care has an integral, necessary part of this work. It can never go away, and we have to hang on to it. There is something that is particularly powerful about residential care. It may not be the diagnosis for everyone, but it is for so many people. It has saved so many lives and will continue to do so. I don't hear a voice standing up for residential care in the current environment, and we are that voice. We will do that. Value-based care and contracting. What is value-based care and contracting? I don't know. Somebody asked me, how many people have value-based care in the association? Well, it depends entirely on what it means. But I'll tell you what, as it is defined, it needs to be defined by us and not the payers. The metrics for returning value to the payer have to be based on legitimate science and metrics that are available. in order for us to get paid. And if we do that, and that's very much what our Foundation for Recovery Science and Education is about, then we will be where we need to be. Measurement-based care practice. Dr. Nick Hayes, Science Officer for Cumberland Heights, will do a session on implementing a measurement-based care system in your program. Social determinants of treatment. I've talked about that already. Competition versus collaboration. Field consolidation. Our long-standing leadership transition. We are transitioning out many of our veterans, and we have been for several years, and we need to be mentoring in a way that replaces that wisdom and brings the field forward. We'll talk about dual diagnosis and behavioral health integration, outcomes research, and how the referral sources and online marketing business has changed so dramatically. And of course, bad actors and ethical violations. But here's the good news. We know this. We have data to show this. Anybody who tells you this isn't true, it doesn't know what they're talking about. Treatment works. People who get treatment get better. We just released the 2024 Force Report. It clearly demonstrates, as others have, that people who get treatment get better. People who get more treatment get even better. More is better. And many people in this country recover. At least 25 million people in the United States identify as individuals being in long-term recovery. But you know the bad news, 85% don't get treatment. Why? Well, they lack coverage, they lack access to care, the stigma of addiction continues to be a problem, and there's consumer uncertainty and confusion about the need for treatment and its value. Many people who need treatment don't want treatment, don't seek treatment, right? It's not just that we're not providing access. There is a lack of adequate education to help people understand what they need. So that's where NAATP comes in. Our association is 45 years strong, growing stronger. We have 1,000 treatment sites across the country. This map, which you can't dissect from where you sit, but is in your app and will be available on our website, shows you those programs across the country and breaks them down into size and type. It's interesting. You'll probably want to take a look at it. Tonight, or at 4:30 this afternoon, please come to the membership value session, and we'll describe in greater detail what we do. But here's what we do. And the situation that I've described requires a national response by a professional society of value-based, high-quality providers and advocates to lead it. And that exists in three components. First, we establish our values, and we do that through our ethics code and our equity work. Secondly, we set quality assurance standards, and we do that through the Quality Assurance Initiative. The second edition of our Quality Assurance Guidebook comes out this year, and the Foundation for Recovery Science and Education. And then we bring those things together in a national advocacy program that is our public policy program. This is the simplest way to think about the work that NAATP does. One of the reasons you want to be in this association is because membership means something. It is not simply sending in your check. We send checks back. You need to be licensed for all services in all locations, accredited for all services in all locations. You have to comply with the ethics code and agree to remove yourself if there's an ethics violation. And you have to comply with the guidelines of our Quality Assurance Guidebook. That means that, as John Curtis said last night, we are the short list. There's a lot of treatment centers in the United States, but we are the short list. And you end up in the AID because of that. And I love what Jay said about if you want to do a strict ROI, and we're bigger than a strict ROI, you can do that by looking at the returns from the AID. It is where the top providers are found. It's where quality values-based providers are found. And when you have that seal on your site, it means something, and you qualified for it. You earned it. Our members treat over 100,000 patients per year. It's sort of hard to come up with that statistic, but that's at the least, our members treat over 100,000 patients a year. We have three categories of membership. We're centered on our providers, which are licensed and accredited treatment programs, but supporters are programs like 12-step immersion that aren't clinically licensed treatment, but support recovery, and our affiliates, who support our centers through the various services and products that they provide. And all of those are important, and they're all found in the AID. This is the field that in which you exist. This is our membership. This is the bubble chart. Our members exist on a continuum of gross annual revenue of under $3 million a year to over $250 million a year. And in some cases, well over $250 million a year. This chart represents our membership. The bubbles indicate the size of the member by number of facilities. The larger the bubble, the more facilities. It's pretty clear that our member Acadia Healthcare is our largest program. What's interesting about this chart is it shows the continued march of consolidation that I've talked about before. You see all the little dots? Those are the traditional centers that I spoke about when I began a few minutes ago. They are the smaller, individual, freestanding, typically not-for-profit treatment programs that once made up probably 90% or more of our organization. They are the majority of members, but they represent the fewest number of sites. And that's what this chart illustrates. Come tonight, come at 4:30, and we'll talk to you about our membership value. Please stop by the Force Room. Force is the biggest thing we've ever done. Our Foundation for Recovery Science and Education, headed by Dr. Annie Peters, was launched in 2020, right during COVID. And it has taken hold. We have over 200, we are collecting data for over 200 treatment programs. We have approximately 400,000 unique patient episodes that we can study. Nothing like Force has ever been done because it's really hard to do. There's a reason why it's never been done. Nobody would do it. We finally said we can't kick the can down the road anymore. We're going to do this. And it has really taken off. I encourage you to stop by the Force Room, learn about Force, become part of Force. Many of you are. I thank you. I thank the growing number of electronic medical records who are assisting with the program. Force is the most colossal program we've ever undertaken, and I think in the end, it will be the most impactful thing we've ever done. That big bubble, so we love bubble charts at NAATP. This is actually science, folks. This is the SAMHSA locator versus the NAATP AID. The big bubble is SAMHSA. Now, SAMHSA does, I'm not criticizing SAMHSA. All SAMHSA has done here is collect anything in the United States that can be in some way recognized as a treatment program. And that's the bubble based on the sizes, right? And there are at least 15,000. And then you see us, right? NAATP there's no criteria for being in the SAMHSA directory, nor do they pretend that there is. It may be a way to get an understanding of what entities exist, but it is certainly not a way, forgive me, SAMHSA folks, it is not the way to find treatment. Well, don't even forgive me. You know that it's not the way to find treatment. That's not how it works. But ours is. John Curtis last night talked about the short list. We're the short list, and that's what the AID is all about. I want to conclude as I introduce Congresswoman Dean with a quote from William White. Most of you know who William White is. He is the foremost thinker, scholar, writer, researcher in the world in which we live. He's a remarkable human being who from the very beginning, he's worked in this field for many decades. He's absolutely brilliant. We rely on him for understanding. I rely on him for much of what I have come to understand. He's a very brave man because he is grounded in the center of what we do as a spiritual entity, but he completely embraces innovation and science and is not afraid to make steps forward. And so his writings are absolutely phenomenal. If you do not have his treatise, Slaying the Dragon, on the history of addiction and addiction treatment in our country, get it. It's an unbelievable thing. He also has a website of all of the William White papers, and he just published this in April. And Dr. Peters was working on it as it concerns Force, and it was his latest piece, and I talked to him about this after he wrote it. He said, Marvin, I saw this as kind of a swan song, so I tried to pack a lot in, but this is the last paragraph of the last thing he wrote. I think he'll continue to publish. I hope he does. But he was pretty much trying to fit it all in here. And he wrote, "Let me say that a now past and aging generation of recovery advocates dared dream of a science of addiction recovery. We envisioned and worked for years towards a day when research scientists from diverse backgrounds would be called to pursue a well-funded recovery research frontier. Today, with the opening of this event, our hearts are soaring. The degree to which our dreams will be fulfilled is in the hands of those of you here today." He said that to a different group. I asked him about presenting it to this group, and he said, "It's for you too." Right? So thank you, Bill. I believe that this is exactly the case. So I've been yakking on about our center, right? We need to innovate, but we need to hold on to our center. What is it? Transformation of human beings from sickness to well. That's what we need to hold on to. My wife, she allows me to say this, recently celebrated her 17th year in sobriety. And as the years go by a little bit, the anniversaries maybe don't have quite the same impact. You know, I think folks who have a lot of years will tell you that. It's not that we don't notice them, but it's not the same. And for some reason, when she and I were talking about her anniversary, we went back to the days we were sick. We went back to the days we entered residential treatment. We felt the pain and hopelessness that we felt at that time. And it's really important to go back and connect to it once in a while. I hadn't for a while. I don't work in the treatment milieu, right? I work in this association that works for you, but I don't see patients, and I forget. And I forget how sick I was. I forget that I was hopeless and wanted to die, just as she did. And our lives, and something happened. Because of the work that we do as an association and its members do, I'm alive. And I live a wonderful life with a wonderful human being. And it's because the process transformed us from sickness to wellness. And if that is not the end game, we're wasting our time. That doesn't mean that the instant you go to residential care, you're well, or even that you're well when you leave it. One way to think about it is that we arrest the disease in treatment, and then the continuum begins. And healing occurs in the community, right? Recovery occurs in the community, the continuum of recovery. And there are many different pathways, but this is our center. And I ask us to hold on to it as we go through the rest of the conference.